Hi there.
Hi,
Hello.
How you doing, London?
good. How are you?
Good.
Good. Glad to see that this event is happening. Looks very interesting.
Yeah. Now, Junie, looks like you had some slides already up. Uh,
Yes, do you want to go ahead and
no,
share your
I
screen?
reoriented them a little bit, so I'll just share my screen.
Okay, perfect.
But maybe I should go ahead and share it as the intro slide while people get on.
Amazing. Yes.
All right, let me do that. Hmm. And are we seeing the right screen, Junie?
Yes,
Yes.
we are seeing it. Yeah.
Great. Good afternoon, everyone. This is Greg Kirk, Vice Dean for Research. We're going to give it a few more minutes, and then we'll introduce our speakers, provide a bit of overview, and get started. I see Michael has joined Rohan. Um, I'm not Rohan. Have you joined yet? Well, we'll definitely give it a few more minutes, waiting for Rohan to join us as well. Hi, Rohan. Hi, Michael. Thanks for joining us today.
Good.
Um, so I've been very interested in digital twins, and as we discuss topics for our phase series, most people didn't know what digital twins were, hadn't really heard much. So that seems like a pretty appropriate topic to introduce ideas and concepts in AI and applications of AI in public health. That's why we started PHAISE, Public Health Plus AI Strategic Endeavors, a few years ago, shortly after ChatGPT decided to uproot many of the things that we do. We said we would start this as a phase task force for a 1 year period, but we've decided to just each year when the annual renewal came up, we decided like there's too much going on with AI and public health, and we need to continue our discussions. So thanks everyone for joining this afternoon. We've got a good crowd that have joined virtually, and we're very pleased this afternoon to talk about digital twins and their applications to public health. I am Again, I think the first step in this discussion is to talk about what digital twins actually are. They're virtual representations of people that mimic the structure, context, and behavior of that physical person. They're dynamically updated in some type of near real time or some type of interval, and they inform decision making through some predictive analytics. Many of you have seen the movie, at least, of Apollo 13 in 1970. An explosion on board disabled the spacecraft tens of thousands of miles, and the NASA engineers and tech crew in Houston went to their sort of high fidelity simulators, and they prototyped how to deal with oxygen and power source and the burns. And if you watch the movie, you've heard the story, they were able to safely return the astronauts. But this idea of having a virtual simulation where you can try something out and see if it works and optimize the approach has been sort of heralded. Apollo 13 as this first sort of example of a digital twin. Obviously, this isn't a digital twin, it was a real life simulation. But this concept of having a synthetic twin where you could go through opportunities to optimize a variety of different things is the idea. In healthcare, we're talking about an individual patient, and we can create this digital twin that incorporates a variety of data sources, whether that's self-report of the patient, their clinical records, their genomics data. But the important point for digital twins that differentiates it from some of the other modeling approaches is that there's interaction, that there's a feedback loop that goes from the synthetic twin to the real life twin, can inform some decision making, and that loop sort of solidifies this digital twin approach. To date, there's been a lot of talk about digital twins for health. The market for digital twins is viewed as billions of dollars, but it's highly complex. And in most cases, what I'm most familiar with are sort of organ-based twins. You have a digital twin of someone's pancreas or their heart. There's work done here at Hopkins where you can use EKG and imaging and other clinical data to develop a twin of someone's heart, and then go through and predict what ablation procedure would be appropriate prior to actually taking the person back and performing the ablation procedure. There's also been some clinical approaches. In most cases, these have been sort of very targeted. Glucose monitoring to, real-time digital twins that's going to monitor and adjust glucose levels, or perhaps like in this example, I think it resulted from a very molecular-based cancer-type treatment. But there's a movement to also extend this to populations, and the Kingdom of Saudi Arabia has gone all in digital twins and is looking at a variety of different approaches to helping digital twins modify and inform health decisions for patients and populations. So with that as a very introductory overview, I'm very pleased that we're able to have two speakers, and I'm actually going to reverse the order of the pictures. We're going to start with Dr. Rohan Khera. He's Associate Professor of Cardiovascular Medicine at Yale. He's really both a cardiovascular scientist. He directs the Cardiovascular Data Science Lab at Yale, which is really focused on using data to inform prediction of cardiovascular risk, and that's what he's going to share with us. He also serves as the clinical director for the Center for Health Informatics and Analytics at Yale, at least the Center for Outcomes Research and Evaluation at Yale, and he's associate editor for the Artificial Intelligence and Digital Health at JAMA. So we're going to start with Rohan to share with us about sort of digital twin applications in predicting cardiovascular risk. And then we'll ask Michael Millar, who's the CEO and founder of Verto Health. It's a company that really uses population health data to help individual patients navigate a healthcare system. And this is using AI-enabled digital twin technologies as part of the Fraser Health System in British Columbia. So we're going to start with sort of a personalized, patient-focused approach related to cardiovascular disease, and then hear from Michael about the population level approaches about sort of navigating health services. Michael is both balancing the corporate world as CEO of a company that does this type of work, but he has a background with a Master's of Health Informatics and is a computer scientist and still has a faculty adjunct lecturer role at the University of Toronto. So with that as the introduction, I'd like to ask Rohan to go ahead and you can share your screen and we'll have you start out.
Thanks, Greg, and thanks everyone for having me here. Can everybody hear me okay?
Yes, looks good.
Perfect. And can see my presentation too?
Yep, looks fine.
Perfect. So, again, thanks for having me here. I'll start with that the introduction. I appreciate, the background on digital twins. So I will try and not, mention many of those things in as much detail, but rather focus on an case example that we chose to specifically leverage digital twin technology, especially in the era of deep learning and artificial intelligence. There are no disclosures relevant to the talk today, but I've included my usual disclosures for discussion. I think it is always helpful to evaluate everything we do today in the context of providing personalized patient-centered care, even if we are looking at population health. And largely that's because, whatever we do are now doing is personalized care. The next frontier is to launch that at a population level. And today we are living in this era where data are plentiful for each patient and each individual. Whatever we might think, from wherever they live in their communities to large-scale assessments, we have a lot of healthcare data that's available for individuals. And we have currently mostly leveraged, advanced tools to detect diseases or improve our clinical care workflows or define, new disease subpopulations that can, be targets of targeted therapeutics. But there are many gaps in providing personalized care, and that is, we can't really do things individually and plan procedures for an individual because most of our models are still probabilistic in their intent. We can, define, population, a person at risk and so forth in our individual models. But where to target and where is a person's pathology located? Very important for some of the more anatomically driven tasks. It's difficult. And often it's more challenging to provide real-time feedback, especially if you're largely dependent on probabilistic models, which leverage one or two pieces of information. And then finally, there is this huge idea of what would a clinical trial that you do in a large population mean for our patients, the patients that might be seeking care at Hopkins and so forth. So, the idea of digital twins is to sort of build upon this frontier of precision medicine and leverage data from a patient, generate a virtual representation of a patient, and then make decisions and guide care for a patient, and then learn from that experience of that patient for other examples that follow. So, at present, I would think about digital twin technology as leveraging patient data, like, electrocardiographic imaging data, any high quality, high fidelity data that is done in diagnostic labs. And the more sparse but more commonly available data, electronic health record, and maybe a little less commonly available data on omics, which is genomics or others. This is fed into a model that is able to create a digital twin of the individual, and then based on examples of other individuals that look like the individuals at risk and their outcomes, we can essentially plan a treatment strategy for a person and identify their individual prognosis and risk and continue to do simulations within this environment that can guide the care of the patient. Increasingly, we have access to other variables and community-based systems. So in the future, we will have the level of data needed to really define a person's representation, and then can generate maybe using variable data to guide what a clinical ECG might look like, and improve the efficiency of clinical trial operations because we will have the high quality data to measure and really improve outcomes. So and then I think these simulations and the effects they have on clinical care will actually guide the model development in the first place. Again, this is a conceptual framework of what a digital twin in cardiology might look like. But what has happened so far is the digital twin models have been largely using one or two modalities like electrocardiogram, which is an electrical representation of heart, with imaging like magnetic resonance or MRI, or CT or MRI, and so forth, and building these models that rely on either the electrical, mechanical, or anatomical structure of the heart, and then using these existing, statistical models to define the ways in which a heart might be modeled. What we expect is happening, not expect, what is happening at scale now, at this modeling is not based on statistical principles or like fluid dynamics or electrical maps, but is largely based on newer models like convolutional neural networks or recurrent neural networks or autoencoders, or models like that are used for large language models like ChatGPT like models. They can encode information from any type of data, not just language, into large, rich representations of an individual and from the milieu or the environment that they're sought from. So and I'll give some concrete examples. So there has been an idea of doing individualized procedure planning, for example. So we've seen this representation with existing models of combining the anatomical and the electrical models of the heart. Anatomical coming from MRI and ECG giving rise to an ECG model, and then defining where a person should undergo a procedure called AFib ablation, or where their electrical activity is anomalous enough that doing some sort of like ablation is going to have an improvement in the success of the procedure. Similarly, very similar example is feeding the anatomical and electrophysiological information into a different type of model and then localizing where an area might be scarred out. So essentially, this example generates an area where a heart may be scarred and might be an important place to monitor for outcomes. And then there is more, real-time information. When we do valve placement, we want to know what's the structure of the heart root of the aortic valve, for example, where the heart valve will be placed. What will happen to the, sorry, what will happen to the blood flow through this artificial valve, and what will happen to the conduction around the heart, the electrical conduction, if a valve is placed in that location, really allowing us to optimize how a valve should be placed. Again, it allows us to really, in real time, plan a procedure properly. But I think what is most important for a population health discussion, and I think that's where I want to spend the last couple of minutes, is doing a clinical trial simulation. And the goal here is that we have spent a lot of time thinking about clinical trials as a place where you learn about the average treatment effect differences in a set of enrolled individuals. But there is often a challenge about how do we, conduct high quality clinical trials, which are very expensive, and can we optimize the trial operations by using existing data more effectively? Second, there's been a big interest in understanding whether we can really understand the implications of a trial for a new population. And so those are the examples that our group has sort of worked on. The first example is clinical trial efficiency, and this is a very growing area of a synthetic control population where we enroll largely patients in the intervention arm, and only a minority in the control arm are enrolled prospectively. The remaining are controls that are generated for existing data and resemble the clinical trial, the intervention arm, but again, with the concern about how well we can adjust for confounding in those settings. But digital twins have been increasingly used to generate these controls. An example that I want to delve in more detail is translating evidence to clinical practice. So let me give you an example of what it really entails. Say I am conducting a randomized clinical trial for any intervention. I have a full population of people to enroll in a trial. Trials are not probabilistically enrolled. Whoever chooses to participate, consents to participate, enrolls in a trial. So the characteristics of patients enrolled in a trial, they might include people like the population that they're recruited from, but the distribution of the patient's characteristics across the trial differ substantially from those of the population. So some groups may be underrepresented, and the population characteristics differ remarkably. You can go back to the literature for most conditions. We have shown that people enrolled in a trial are more frequently younger and more frequently men than the people with this condition in the population. So we wanted to test how would you understand whether if I do a trial in this population, which is selected, how will I generalize those results to this larger population, which looks different, especially because often there is a difference in treatment effect. There is treatment effect heterogeneity across included participants, but we don't know how to really translate that to the population. And the bigger problem is, say we want to run a trial in one population, and I had to adapt it to my own health system. How would I know whether that trial's results truly apply to the population to the same way if it was run in my clinical population? But the major challenge is that we often do not have the gold standard in the new population to test any methods. So we wanted to ask this question whether there is an existing example which can be used more effectively. So the example we chose was the SPRINT and ACCORD trial. SPRINT trial and ACCORD trial were both clinical trials done in large preventative health settings where we tested the effect of intensive blood pressure lowering or achieving a upper systolic blood pressure less than 120 versus a control population where the goals of systolic blood pressure were less than 140. The SPRINT trial largely enrolled patients without diabetes or prior stroke, and ACCORD trial enrolled patients with diabetes. But the results of the two trials were completely discordant. While the SPRINT trial was a positive trial, a remarkably positive trial, the ACCORD trial, the effect estimate was smaller, and also it was not a significant trial. So we've always had this challenge to interpret the results of this trial because just having diabetes should not conceptually change the results of intensive blood pressure lowering. Again, there were minor other differences in the trial, but this was a large major difference in the trial. So, we asked this question whether if SPRINT enroll ACCORD-like participants and ACCORD enroll SPRINT-like participants, would SPRINT and ACCORD's results be different? Again, and how would we ever achieve that? Because these trials cannot be rerun again in a historic population. So this is where we decided to leverage digital twin technology. We assessed this idea that if you have an index RCT, for example, SPRINT, and you had an external cohort, for example, either a cohort or a new EHR population, could we create a digital twin for the index RCT, which had the option to update the covariate distribution from a different population? So for this work, we identified shared covariates across the two trials, the SPRINT and ACCORD trial. Then I think the challenge often in digital twins, using especially something like deep learning, is that if you allow all variations and combinations to exist, the degrees of freedom are too large and the model becomes too complex to actually work. So instead, we actually leverage something called DAGs, which are direct acyclic graphs, which are associations, known associations between cohorts. What is an exposure? What's the intervention being tested? What are the different covariates? What are the association between covariates and the outcomes? And again, these are very loosely defined by experts and clinicians for the set of covariates that are table 1 characteristics, for example, from the SPRINT or the ACCORD trial. These are expert defined. And then we created this conditional generative adversarial network to generate RCT digital twins. So essentially what we made is a tool that could generate the SPRINT trial, for example, given a set of covariate distributions. So the first example, we just made a synthetic trial simulator where every time we would run it, it would just generate another set of SPRINT trial results. What it really means, it will generate a full cohort of populations enrolled in the intervention and control arm. And when you tested that particular twin, the results of that twin would be like the results of the SPRINT trial. What we did after that was we took the ACCORD trial's covariate distribution and told the generator of this digital twins to now not sample from the covariate distribution of the SPRINT trial, but instead from the ACCORD trial. So this is the example of what we found. So here the ACCORD trial, which was null, is in the green, and the blue is the SPRINT trial, which was positive. So on the left, we ran a lot of these ACCORD trial simulations, where ACCORD is a null trial. We said, okay, let's run it conditioned on the SPRINT covariate distribution. And we found that in 10 out of 10 runs of this ACCORD digital twin, the trial would be positive had ACCORD enrolled participants like SPRINT patients. Again, independent of the diabetes status. If they had enrolled the other covariates like the SPRINT population, it would be positive. On the other hand, had SPRINT, this overwhelmingly positive trial, enrolled ACCORD-like participants, in 9 out of 10 runs, SPRINT would have been null. Again, suggesting overwhelmingly that the results of the ACCORD trial are largely guided by the population characteristics, and the differences are explained by that. And I think our biggest thing here is that we can we're working to further understand the limits on this technology, but this allows us to enable, to really get information about a clinical trial and its implication for new populations, where running a new trial would be challenging, but knowing that information would be very helpful. And for more details, I put in a QR code, and the papers are accepted in NPJ Digital Medicine. But the full preprint of the article that's set to come out in this journal are available on medRxiv of that QR code. And I think the implications of all this work is that when we are able to convert RCT to a trial level digital twin, we can really get generalization of that RCT to a large population, EHR, or whatever population that thinks. There are, of course, some challenges. How do we assess when there is no gold standard? How do we compare outcomes of something that is just a simulation? How do we ensure data privacy when volume and variety of data is the value that especially the deep learning based twin technology provides? How do we ensure that people are adequately represented in the development population so we can actually translate that? And how we can confirm that run after run remains reliable? And I think these are things that many of us are working on understanding better. And I think the biggest thing that we have to do is to really learn for investment at scale and build regulatory systems for digital twin technology, especially those that leverage many information streams, and then also develop tools that can be deployed without data sharing across systems. And that is, I think, that's the value add of the system. So if I may leave with what might be the key blueprint for successful twin deployment, it's like real-time access to PHI, or protected health information, but in a secure manner. It should be a model that should be fully deployable and resilient to data shifts and drifts, which is easier said than done, but requires constant monitoring. There needs to be infrastructure investment explicitly for running these models so they don't slow down the clinical operations. And then I think there needs to be periodic reassessment of outcomes and external validation to assess whether these tools we build in one system truly generalize. And I think that the major emphasis from our group has been in thinking about how the data will evolve in the future, how models will go from simple mechanistic and tool-based model to really advanced deep learning models, and go from simple procedure planning or pathology inference to really individualized risk stratification and the holy grail of precision care, leveraging data effectively. We wrote a review article on this topic in the European Heart Journal, which I've also put up here. And I thank, Phyllis Thangraj, the lead author on the study and a cardiology fellow at Yale, for leading all this work and for some of the information I presented on the slides today. And the CARS Lab team that supports all the work that I presented. With that, I'm going to hand it off back to you, Greg.
Thanks very much, Rohan. We greatly appreciate that. We're actually going to move on to Michael and save our questions after both speakers have gone. So Michael, feel free to get your slides up. We will open it up and you guys can put questions in the chat or just pop yourself on screen and ask the questions after Michael gets his chance. Go right ahead, Michael.
Okay, I actually wanted to start with the question first, just to understand the audience I was talking to.
Oh, of course. Go right ahead.
Yeah, so I guess prior to coming onto this call, how many people here would generally say, just put your hand up if you agree, if you generally understand what a digital twin is? Just put up your hand if you're like, you know what, if someone asked me to explain what a digital twin was, I'd be able to do it. Okay, so, I'm going to assume 50% because I think the other people are eating lunch.
I don't think it's even that high. And, this is a selected group that came because they had some familiarity with the topic. So I think it's representative. It's pretty unrecognized, even in a school of public health like ours.
Well, yeah. And so before I jump into how our approach is to it, one of the things I wanted to talk about was, and Rohan, it was awesome going through your deck. So I think that there's this extreme bias towards the physical space digital twin. Whenever people think about digital twin, they think of a physical copy. And when you're riding in a Tesla and you see the little screen in the middle and you see all the cars being basically modeled, that's actually a digital twin. It's a good example of a digital twin, right? Because it's using its real world sensors to say, hey, I think it's a truck, I think it's a car, I think it's everything. So if for the layman, I think that that Tesla image of a digital twin is good. But transparently, I'm obsessive about computers. I played computer games when I was a kid. And so I could immerse myself inside these virtual worlds, right? And so when I think about digital twin, I think about gaming. I think about playing a game where I'm jumping around. And one of the important things I learned when I was gaming was that the digital world, although had similarities to the real world, also could do crazy things. I mean, I played games where I could shoot magic, and I haven't seen magic in the real world. So you can do things that don't exist in the digital world and track them in ways in the digital world that you can't in the real world, right? And so Rohan also gave an example there of where don't only, you take the physiological of the MRI and you can overlay the electric kind of ECG actions on top of it. And so the nice thing about the digital world is that you can layer these different data layers on top of each other, right? And so the reason why I wanted to preface my slides with this is because the entire purpose of what we did with our company, and it's actually like it was an idea that I had in school at the very beginning. Well, maybe Abigail, before I go forward, any quick question, maybe just to set the direction.
I'm sorry, I still had my hand raised from
Okay. No, never mind. So it's fine. I thought it was going to be shaping, but the whole thing is what I thought about, and it was funny because I was working in a banking job because I always wanted to work in healthcare. I just used that as an excuse so I could start my company. But I was like, maybe we're looking at healthcare wrong, right? Whenever we apply digital twins to healthcare, we always need to root in the physical. I'm like, when I think about healthcare, healthcare doesn't, you do diagnosis, then you do differential diagnosis, and you're trying to isolate the problem and then do a treatment, and then based on the treatment, adjust your diagnosis over time, right? Like you're very much going through a decision pathway in your head. And so I said, what if we modeled the digital twin world around that? So, and that's when it came around this concept of clinical concepts, right? So if you look at, like, let's take a cancer pathway, for example. If you look at a cancer diagnosis pathway, you have a suspicion, you do a mammogram, you come in, they look at it, they think it's there, they do a biopsy, they move forward. Then based on different things, you could go inside one stream where you're doing chemotherapy, another one where you're doing surgery first, maybe you're doing neoadjuvant chemotherapy, you're doing adjuvant. Like there's so many different ways that clinical journey will evolve as you go forward. And what I ask myself is, your physical position in the world has no relevance towards how you get treated in your breast cancer pathway. What's important are what are the key clinical items that you have? Like what are the specific diagnostic findings? What are your genetic characteristics? What are these different things? And so what I wanted to do, the thing is when you create a digital twin, you can create the data that you're creating the digital twin with. That's something that you can create as a rule. And I said, okay, I don't care about physiology so much. I don't care about that. What I want to do is I want to look at their clinical characteristics. I want to look at, like, do they have what's their genetic profile? What is their socio, their racial descendancy? What is their familial kind of impacts towards they have that? And what we call those are clinical concepts. And so the way that our platform works is we use AI to basically look inside EMRs and pull out these clinical concepts to actually find it inside the data. So we use everything as simple as just direct integration. So some of this data is actually just filled in inside a dropdown into there. And then we also use AI to read like unstructured notes. So let's say that you're looking at a genetic consult, or if you're looking at a family history note, we're able to look inside that and pull out actual like SNOMED, CT terminologies that are equivalent to things that you might have just discussed as a family history with your doctor. And what we do is we take the data directly from the EMR as well as from the AI detected clinical concepts, and we use that to create what we call a consolidated longitudinal digital twin. And so basically what that means is if we detected, if you did a test a biopsy at this date, you did a pathology test, and then they found out that you're ER positive, your tumor is ER positive, those three concepts would be timestamped and put inside your digital twin. So our digital twin not only has the reality of your health condition right now, but it also has a temporal. It's like a past, and to current view of exactly when those clinical concepts are created. And so the other nice thing about it is, like Rohan mentioned, you can stack different things that you have. So you can have essential information, you can have health service data, all these different things we put inside this digital twin. And so like one of the, like, SDOH data does matter, right? Because, how your pathway gets treated is dependent on the resources that you have around you, right? So there are breast cancer, like how a breast cancer pathway is dealt with in downtown New York is very different from rural Alabama. And so what you need to understand it is based on the types of resources that they have there, the types of things that they actually support at that given time. And so kind of like our whole goal here is that through deploying our platform, we have different stages of evolution that we go through. And so I will say with most of our customers, we're either at the foundational level or at the population digital twin level. And so at the foundational level, we're just trying to understand a snapshot of the current patient population's health status throughout an entire ecosystem. But the whole point of creating this digital twin that's composed of those different, and so I'll tell you, the foundational digital twin focused on 6 specific things, and we've aligned it with the HL7 FHIRE. Has anyone heard of the International Patient Summary? Think of it, ePatient Dave advocates for it. It's like the 6 basic things that you need to know about a human before you can do a treatment, some type of intervention on them, which are diagnoses, procedures, allergies, immunization, lab results, as well as, diagnoses, procedures, conditions. Of course, conditions, the most important one. And so those 6 things are what we call our foundational digital twin. And so the whole aspect that we use AI to integrate, bring this data in. So just how Rohan said, AI has completely changed the game. AI has made it so that you can look at dirty real world data and really quickly create digital twins out of it. But then once you create those digital twins, it's really, and if you could do it near real time, and this is why I've always obsessed about creating near real time digital twins. And it was kind of good because Rohan called it out, is we need to get there. We need to have some way that we can respond to dirty data, but still create a visual representation of it. Because once you do that, you can use that digital twin for 3 different things, right? And so the maturity that we have, like the first layer that we use is just surveillance. Right? So if you're able to look inside EMRs, pull out conditions, procedures, diagnoses across a population and understand the evolution of those over time, well, now, when you think about value-based care, like the whole point is it's trying to incentivize people, keeping people healthy over time. But the activities that we do to support value-based care are very reactive. Like you do chart review and you do all these things. Whereas with surveillance, now real time, you can be like, oh, okay, I got this new diagnosis. Check the service ecosystem within that same digital twin. Oh, wait, they don't have access to these 3 services. Well, we already know now that that person is not going to be supported in their value-based care journey right off the bat. And so this is what real-time digital twins can be used to change it so that instead of waiting an entire year, the payer realizing that, oh, we forgot to put this care gap in, and then they put it in. Now you can do this real time and you can put this in the hands of the providers, which brings us to automation, which is where that's literally what we do. We use that digital twin. We see that there's a service gap. We're like, okay, if there's a service gap, let's just send in a referral to this person so that they automatically get onboarded. So imagine like once you get a lab test result back, that result actually creates a referral to your care gap that you have inside the area. And so the nice thing is that the US value-based care has advanced so much that now payers and providers are incentivized to actually do this correctly. And so now this is where you can bring in automation. But then you can do even crazier things with the digital twin, which brings it into the simulation level, right? And so the first thing one of the things that we're doing out in the west coast of Canada is we're taking all the people in the digital twins and we've added physical space to them. And so now we're able to say, okay, based on acuity of chronic diseases in different areas, do we have the necessary urgent care, primary care, and long-term care to be able to help support them in those areas? And now we can also find and detect when there is a care gap when there isn't an appropriate level of services to the actual demand, as well as kind of see trends that happen. But then even within a hospital, they're able to use the same technology to understand how to do better patient flow management. Another thing that we're able to do, oh, sorry, it kind of went over here, but we're able to now make it so that we track pathways. So let's say that we find out in a population that diabetics, once they get diagnosed, they aren't properly referred into podiatrists or the kind of post-diagnosis support that we have. You can actually program that pathway into our engine, and it can detect and understand when people are falling off that pathway without you needing to do all this direct intervention and follow-up. And now with AI, the other thing that you can do is just take that digital twin and give it to a chatbot. So when a person comes to a digital front door and or like a member service portal and they're looking for something, instead of asking generic questions like a Schmidt-Thompson protocol, you can feed the digital twin to it so that it actually takes the context of that patient, understands their differences, and then is able to make recommendations based off of that. So it really changes the way it works. The simulation here is more about how to use a digital twin to change the way that you do service delivery. I don't know what's up with this font, but and then the last thing is the ability to actually bring in wearable data and everything inside the ecosystem that is normally traditionally very segmented, where you have clinical data here and you have wearable data here. One of the things digital twins let you do is they let you layer technology, data very quickly. And so now what you can do is provide the digital twin to the patient, let them embed their wearables on top of it so that they can create an enriched kind of view of how they want to work on it going forward. And so this is some of the kind of work that we're doing with our digital twin technology, both in the US as well as in Canada. And our ultimate goal is to help assist. The real driver that we see is value-based care. Value-based care is aligned with keeping people healthy. Ultimately, it is a monetary program, but it's only monetary to make sure that fee-for-service people better align with actually creating healthier populations. And so we're starting to see the convergence of our technology in kind of bringing healthier populations while helping people optimize their revenue collection. Okay, that's basically it.
Great. Thanks so much, both Michael and Rohan. And we're going to open it up for questions. Wow, exactly on time as I'd requested 20 minutes each, and you guys were completely tuned to your exact limits. So feel free to put yourself off of put your camera on and ask a question, or you can drop something in the chat. While we're waiting for those to, well, go ahead, Nilanjan. Go ahead and ask your question.
Hi, thank you both for an excellent session. I have a question for Rohan. This is Nilanjan.
Would you mind just when you guys ask a question, could you just say what Nilanjan's a biostatistician? Just could you like introduce where you're coming from just to help them out?
Sure. I'm Nilanjan Chatterjee, professor of biostatistics and oncology. So I really enjoyed both the talks. Question for Rohan about the digital twin. Could you tell a little bit about, there is of course, a lot of methods in statistics and survey methodology about how to take a data set and weight, the data set, individuals in the data set to make the distribution looks like another data set. This is the classic methods in survey based on various type of weighting methods, whether entropy matching, propensity score weighting. And could you take a little bit more about the connection of what you are doing with the more classic literature about weighting individuals to make dataset distribution look similar?
Thanks for Nanja for asking the question. And I think I would say most of them are extensions of existing statistical methods. The limits, I would say individualized predictions have always been challenging for any method. Because whenever you have the error on an individual is not computable. Largely because we are doing population-based assessments, and even if a person we say is sampled from a distribution, the amount of I would say noise around that particular predictive estimate is sufficient to make it challenging to do individualized estimates. I think what newer methods are offering and not offering, I would say both ways. Our offering is the ability to compile a larger set of data inputs together So being able to sort of make estimates more precise because of the fact that they can triangulate information from two sources or multiple sources. So and the challenge is, I feel like digital twin is we leverage this term somewhat broadly now, because now you can turn anything into a digital virtual representation. Like we can turn electronic health records into a virtual representation of the EHR. It doesn't, and you can place a person on it and learn about that person on it. Doesn't necessarily have to be the way it used to be. Like, the traditional example is the cockpit of an airplane is put into, you have all the in-person altitude and everything. You can optimize and see the results. But now you have the electronic health record, maybe a clinical diagnostic and all that information, and you can create sort of like a normative distribution on each of them and see where they overlap and where a person might be on each of this distribution in this sort of more than two-dimensional space. And I think that provides precision. But again, even now, we don't provide any sort of degree of precision of the estimate or a 95% CI. So many of them are still evaluated on a point estimate basis. Like, oh, you got an estimate. Okay, what was that? Was the sensitivity specificity of that achieving an outcome? So the evaluations downstream are still based on the population-wide assessments, not individual-wide assessments. I was told to do X, I did X, doesn't lead to evaluation of that method. It is done across 200 people. Majority of people benefited from the digital twin guided care is how we would still evaluate. So it's like a little hard to sort of like really fine tune a model to really give estimates and give prediction intervals around that yet. But we're working on some methods that may provide some at least some uncertainty quantification around it.
Thank you.
I think, coming from an epi biostats background, like you see synthetic cohorts, agent-based models, there's causal inference, the weighting that Nilanjan, like this is not necessarily all new. And I think many of us look like, well, what's really different about this versus what we've already done? And some of it seems terminology. Some of it, I think, is this feedback loop, and some of it is the level of complexity and number of variables that can be integrated. But I do think that it's important for us to bring some of the theoretic biostatisticians to the conversation. And with that, Liz, you had a question.
Thank you. And sorry, there's construction behind me if you can hear it. Thanks. I'm Liz Stewart. I'm chair of the biostat department. So yeah, you're getting inundated with biostat questions from the start. So I will confess, so I do have a question, but I'll give a little intro, which is that I sometimes struggle with digital twins. And what I'm thinking about in my head is sort of the balance of assumptions and data. And for things like Boeing and making a digital twin of an engine, they know the mechanism of how an engine was built, and then we can build a digital twin. I do a lot of work in behavioral health where we just don't have really any idea for mechanisms. So I struggle with sort of how to think about the value of digital twins in these complex kind of public health contexts. So my more actionable question is, could you talk a little, either of you, I'm curious if there's anyone doing work in sort of how to demonstrate how much of the result from a digital twin is due to sort of assumptions put in the system about how the system works versus how much is sort of data and sort of what the data is telling more directly. I don't know if that distinction makes sense, but it's sort of one way I often think about these sorts of models of this mix of data and assumptions. And are there ways to sort of show how much of the results are due to one or the other?
I will let Michael take that. I mean, I'm happy to take, but I've been speaking for a while. So Michael, if you want to take that.
Okay. So the whole thing the way that I look at a digital twin is once you create a digital twin, that's why I look at, like, do people trust the data? Would they do something off of the data? And then would they trust a simulation off the data, right? And I think that the less they trust your digital twin, the less further you can go into that model. And so when we deploy the digital twin, our first thing is, well, we don't trust where you got that where do you get that diagnosis from? Where do you get that lab result from? So one of the big things that we did with our technology first was we created covenants. So we're able to point to the actual record and say, this is why we created this assumption in the digital twin. And only once you do that, will they even let you do something basic like automate a response back to a patient. But I will say this, that when it comes to digital twins created from real world data, outside of research, I haven't seen much appetite for using simulations that much, because I think we're still very very uncertain. And like, of course, you're going to use, like, behavioral science is a great one. I would never try using a digital twin and being like, let me just automate your next 10 years of planning for behavioral science using my digital twins. But what I could come to you and say is like, look, I've mapped all the different diagnoses and procedures that you have. And now that you know the outcomes of your patient cohort, maybe you can use this digital twin data to discover which interventions were more successful in a more generic manner, as opposed to a way of using it to do simulation. So I would actually challenge you to think about not only using digital twins for simulations, but also using digital twins as a data concept to help you discover interventions that were successful within your previous cohort once you create that data confidence.
Khadija,
Yeah.
I think you had your hand up. Do you still have a question, or did we sort of address it?
Well, yeah, my question was about, I was going to ask about kind of data biases in the data and how that's considered, but that was sort of answered already. So I guess I do have another question. And hi, by the way, Khadija Ferryman. I'm an anthropologist here at the School of Public Health. I'm also at the Berman Institute of Bioethics. And so I have a question about, and this question is for, I guess it's for Michael, about automation. So you mentioned that, part of how the digital twins will be used is for automation. Can you say a little bit more about how patients and even clinicians might be informed about which aspects of these journeys will be automated, and kind of what the transparency or consent around various levels of automation, what that could look like?
For sure. Before I answer that question, I remember that question very directly. Rohan, you're about to finish and add on to Elizabeth's question. I just want to make sure I can hear from you as well.
No, I don't want to interrupt, but I was gonna say, like, I think the way I think about statistical about like current generation digital twins applied to healthcare, maybe that differs from aerospace engineering, where you mentioned there are mechanists. I built the engine to do this way. Is the fact that they're more statistically I would derive from existing healthcare experiences largely, and I think that kind of leads to Khadija's question too about like biases built into the data. But the challenge with is the fact that we do not have mechanistic explanation, but that hasn't stopped us from assessing current distributions and sort of creating factual and counterfactual scenarios within the data to learn about treatments. But for that, you just need a richer representation. And that's where I think there's a lot of overlap in existing statistical modeling and what's being done from digital twins to extract information on interventions being successful or not. And to Michael's point about new interventions being tested on that as well.
Okay, great. I knew that you had a great answer, and I didn't want it to be hidden. Khadija, I'm going to go back to your question. I'm going to try paraphrasing it. You're talking about there's huge implications for what existing clinical patterns and trust and consent and models will tolerate automation off of a digital twin. And you want to hear a little bit more about that. Is that a good paraphrasing? Okay. A great thing. The number one thing that clinicians don't do is trust the digital twin. They just don't trust it. And so one of the things that we did in some of our clients is we turn our digital twin into an attestation digital twin, which basically means we'll come to you with a clinical decision support. So let's say that you type in a progress note, and we're like, hey, we went through your record, and these are the things that we think are true about your patient. But instead of them being like in free text, there's structured terminology that we pull out. Like, this is a diagnosis, this is a procedure, the timing, and they can attest it. And so what we can do is we can make it so that automations only operate off of attested data. So let's say that they attest that this is a family history. They attest that this is a diagnosis and a procedure. Well, we're like, oh, those three pieces, you should be sending them a referral to this other place. And we make that recommendation, and they trust it now. And so what we found is, and it's really funny because some of the organizations that we went to that they didn't trust us at all, we just said, okay, we'll turn on the attestation. And for the first 2 months, it's a full attestation. And then after the 2 months, they're like, okay, you know what? You've done good enough. We're fine. Just turn on automatic. So I think that there's a lot of trust to that. Then the second thing is the trust has to be on the provider saying that we trust the model. The second stage is for the receivers, so the providers and the patients, to actually say, we trust a digital twin to automate things on our behalf. That's now a consent model where you need to say, hey, I consent to it making referrals off of clinical diagnosis, clinical information, or even more sensitively, off of genetic consults or off of social determinants of health data. And so this is where the funny thing is I kind of knew it, but I didn't know to what extent. But we have a massively complicated consent engine that we've had to implement around our orchestration engine, simply because there's extreme nuances in how you use the data to automate. And don't even get me into caregiver attribution, because once you're in chronic disease populations, it's usually eldest daughter who's going to improve that care, or else it doesn't go through.
So you're actually doing this phased approach of attestation prior to automation.
Prior to creating the digital twin off of it. So we can actually pull out an attested digital twin from our auto-generated one.
There's still the issue of data biases in the data. And let's be honest, the administrative data sets, EMR data, they're not great. They're not so great for social determinants of health. There's a lot of limitations. One of the things we do really well around this school and in many other environments is we have really rich cohorts. But now we're moving from millions of people who might be in an administrative data set to thousands of people with really robust social determinants, patient-reported outcomes, wearable data. And I think that there's this integration of different levels and complexity and completeness of data. I'm interested in, can that really be it seems to me like we should be leveraging the really rich subsets where we have this intensive cohort data to inform the broader administrative EMR data sets. And I'm just wondering if you are familiar with others working on that sort of triangulation of that data.
I mean, I think we have been working on many applications of learning representations of data across many sources. So, for example, we published a study called Target AI in New England Journal of Medicine AI a month ago, where we demonstrated that you can sequentially build an electronic health record representation of a person, along with electrocardiographic representation, along with the representation of the echocardiogram they underwent, and combining all them together allowed you to better understand both the diagnosis of interest and also finding new people that look like the person who had a diagnosis, not only on just the broad diagnostic flag, but on their individualized disease trajectory and outcomes. So I certainly think there is a lot more data there. The challenge with enhancing to, I would say, some of the more environmental and other data have been the fact that they are, some are broadly available, some are based on neighborhood-based sort of, and often it's unclear whether the microenvironment is the environment we're trying to capture is too large. The environment that is available in terms of data are too large than the environment we're trying to capture. So I think the mismatch between the two is one consideration. Second, I think about administrative data sets. I think we have selected subpopulations that have more, richer, availability of these data, say the Medicare population, but the privately insured, unless you have some sort of linkage to an external Optum-like population, you miss that information stream for that. And so I think creates these informative missingness within the data, which I think is very challenging to sort of deal with.
I wanted to ask one more, if you really think about sort of the more advanced applications, as you progress through your sequence of digital twins, Michael, you're going from sort of foundational to, I'm not sure what the most far to the right, the precision twin, I think it was. At some point, you're going to be feeding back to the patient's provider, the patients themselves, maybe the caregiver. And there's a lot of behavioral health, you were talking about these pop-up screens and clinical decision tools. As a clinician, I just quickly click through this sepsis risk score because I'm not dealing with sepsis, and it's just a nuisance to have all these things popping up. So I think there's this reticence of clinicians sometimes to have more feedback and suggestions about things you're supposed to do. And then the same thing, like some of the patients aren't going to be so adept at, deciding pathway A, B, or C if you give them that opportunity. And I'm not sure I trust a chatbot to walk them through it. So any comments from both of you in sort of this last round of questions about what do we need to do? Again, this is relevant for public health. Like we're interested in how to optimize improving the interactions and the behavioral health approach. How do we actually get people to use this data, whether it's a patient or a provider?
Well, so let me answer the question before this and the one that you have, because they're actually linked, right? I think that I've always said to people, if you don't understand Maslow's hierarchy of need, then you don't understand why people don't care about their medical health records like 95% of their lifetime. Like you need to understand that a person, even if a person has diabetes or cancer, how likely they are to adhere with the right things to do to steer them towards a healthier outcome is determined by how they perceive the importance of that health intervention, right? And so for me, there's two things. So I want to first answer, I believe in the quadrupling, quintupling, whichever count it's at, but provider experience and patient experience are way more important than people think, right? And so for patient experience, you have to meet them in their space. And half of the time, the patient is more focused on their wellness than they are on their health. And so if you're able to integrate their wellness app into their health record and adapt it. So like, for example, my sister has an Aura ring. She swears by it. Like her mood changes based on how it tells her what her mood is. So, if you're going to do that, get the Aura ring to tell her to be more complete and more on top of her pressure meds or something like that. So use the mechanism to create the connection. So it's not about chatbots, it's about where they decide to connect. Similarly, we have a youth digital front door where they connect. We said you have to let them log in using TikTok or Instagram or Google or Discord. Let them connect the way that you want to and communicate through the channel that they communicate through. So that's my belief in that. And the nice thing about a digital twin is it lets you do that combined with AI, right? So AI can then take that and change it into a Discord message saying, hey, man, you know that you have mental health issue or like you feel sad if you stay up too late. A simple message can actually work. So we have to be creative. But now let's go back to the provider. Oh my goodness, we have to be creative with the provider. Clinical decision support, everyone thinks is an alert. Let me tell you what clinical decision support is in our platform. What we do, what I said to everyone is they're like, oh, when you discover a care gap, you should message a physician. I'm like, no, what I'm going to do, I'm going to look in their schedule and we see the next time that they're meeting with that patient. And I'm going to send them a note in that morning saying, hey, this is a snapshot of your patient. And here are the 8 care gaps that we've detected. Bring them up in your conversation if you want. That's completely different than sending you a plethora of alert fatigue. So that's kind of the strategy that we're taking.
I wouldn't add too much. We're already at time, so I just want to mention one
Oh,
thing.
sorry.
No, I think it's perfect. The answer was spot on. I feel the implementation as a field is in its is complete in its own right with its own set of rules and learning. So and I feel some of the from my experience, it's some of the more facile systems that are built around implementation actually incorporate the learnings from before, which is how to sort of meet patients where they are, give them something that they would value clearly. And I think the biggest thing I can say in all of this is it is not how we perceive things should be, but how people currently interact with all the information already, which will determine how they interact with more advanced forms of that. So patients who already check their MyChart are more likely to interact with a chatbot. And maybe I think even that has to be modeled and personalized. And I feel that we're trying to increasingly do that, whether we can personalize how to get to people and get them to respond in their way that they already interact with systems.
Great. Well, I want to thank both Rohan and Michael for sharing their insights and their experience with digital twins. I think this is a good illustration of a topic that many of us are not that familiar with, but there's a lot of growing interest. There's a lot of opportunities to approach it from a public health perspective. I want to also, so thanks again. We're giving you the standing ovation, Michael and Rohan, virtually. I also want to remind everyone that abstract submissions for our AI Research Day coming up, I believe it's March 23rd, are due this evening at midnight. Jeff Leake, who used to be here at Biostats and is now heads up as Chief Data Officer at the Fred Hutch, will be our keynote speaker, and there'll be opportunities for doing posters. So with that, thanks everyone for hanging on through the entire hour plus a few minutes. And again, thanks Michael and Rohan. Have a
Thank
great
you.
afternoon, everyone.
Thank you.